The INSORB Absorbable Skin Stapler, the absorbable new standard for skin closure. This instructional video is titled, How to Minimize External and Superficial INSORB Staple Placements. Please refer to the instructions for use for complete instructions, indications, contraindications, adverse reactions, precautions, and warnings. This video does not replace a thorough in-service by an incisive surgical sales professional, including practice with a hands-on training model. Additional instructional videos are available at INSORB.com. Even the most experienced user may inadvertently place INSORB staples externally, percutaneously, or superficially, slightly below and proximate to the epidermis. Superficial staples may be visible and palpable. External and superficial staple placements may occur with improper technique or when using the stapler in tight spaces, such as when placing the final staple in the incision. Externally placed INSORB staples may unintentionally perforate the epidermis, resulting in a percutaneous and partially external staple. Externally placed staples may be difficult to see at the time of surgery and often are not apparent until 3 to 4 weeks post-op. These externally placed staples should not be of concern and may be easily removed in the office or simply allowed to fall off with time. Please note, this staple did not spit, but was placed percutaneously and typically does not cause inflammation, redness, oozing, or pain. The INSORB absorbable staple is comprised of a benign polymer characterized by a remarkable lack of erythema and inflammation around the staple. As well, superficially placed staples may occur due to improper technique or when staples are placed in tight spaces or thin skin. After closing a radical neck dissection with INSORB staples, a large hematoma required emergent intervention and the cutting of the INSORB staples to gain access to the wound. At 11 weeks, the superficial INSORB staples are visible and palpable, but again, note the remarkable lack of inflammation surrounding the staples. The staple polymer continues to degrade and becomes fully absorbed as shown at 26 weeks and at 1 year. To understand why an external staple placement or superficial staple may occur, it is important to review how the INSORB technology works. As the clinician squeezes the lever, the compression arms shape the skin to present the dermis to two surgically sharpened needles within the incision. The needles advance to capture a precise bite of dermis on both sides of the incision while placing the INSORB staple entirely within the dermis. The hooks of the staples secure the tissue. The key to minimizing external staples or superficially placed staples is to make sure the tissue completely drapes the tissue capture zone in the proper orientation. To assist the clinician, two blue triangles have been placed on the right and left underside of the nose of the stapler. The tissue is properly draped when both blue triangles on the stapler nose are covered. If one or both of these blue triangles are not covered, the advancing needles will unintentionally puncture the epidermis, thereby placing a percutaneous external staple, or the staple may be placed at a bias and too close to the wound edge, thereby resulting in a superficial staple. To minimize externally placed or superficially placed staples, it is important to place staples level, in an orientation horizontal at the proper depth. First, keep the stapler level with the plane of the skin, that is, not tipped or pointed downward. This is of particular importance when closing incisions that are not flat and linear, such as in the breast or the groin. Placing staples while tipping the stapler may place the backspan of the staple too shallow and at the wound edge. Next, in tight spaces or when placing the final staple, it may be necessary to rock the stapler from side to side to ensure that dermal tissue covers both blue triangles on the right and left underside of the stapler nose prior to firing. It is essential to grasp tissue directly above the last staple placed for every staple placement. Do not place multiple staples with a single grasp of tissue. Placing multiple staples with a single grasp may place staples in a shallow, biased orientation, resulting in superficially placed staples, or may perforate the epidermis, resulting in an externally placed staple. To ensure proper staple spacing at 7 mm intervals and minimize staple placement issues, grasp directly above the last staple placed and lift, and firmly mate the stapler with the forceps directly below the arrow on the stapler prior to firing. To easily locate the position of the last staple placed, look for the slight indentation or dimple in the epidermis where the tissue is approximated. To minimize external staples when placing the final staple in the distal apex, first reverse the direction of the stapler. Grasp one of the tissue edges and open the wound sufficiently to insert the nose of the stapler into the incision. Once the nose is in the wound, grasp the other edge of tissue and lift the tissue over the stapler nose. Regrasp tissue at the apex and ensure that both blue triangles on the nose of the stapler are covered with tissue by rocking the stapler from side to side. Lift and fire. In addition, when closing an incision in areas of the body that may have flaccid tissue, such as the groin, areas of the abdomen, or under the breast, it is important to stretch the incision lengthwise either manually or with skin hooks or clamps so that the tissue can be effectively presented to the stapler and that the staples can be placed at 7 millimeter intervals and that both blue triangles can be covered so that external and superficial staple placements are minimized. This tension should be applied to the opposite end of the incision. The proper use of the INSORB absorbable skin stapler will result in rapid, secure, and cosmetic closures and minimal staple placement issues. For further information on the INSORB absorbable skin stapler, contact your Incisive Surgical sales representative or Incisive Surgical at 1-877-2-INSORB, extension 32.